We're going to go ahead and get started, but welcome. If you're coming on and you hadn't already, please put who you are in the chat. Say hello to everybody. We would love to know who you are, where you are from, or anything you want us to know about you. We appreciate it. But good afternoon and welcome to our Ask Me Anything session on supporting individuals to live as vibrant elders in recovery, or as we lovingly call it, silver. And I'm one of those people now, so I love the actual term vibrant, because I want to be that vibrant elder now that I'm in that category. So we're excited about it. We're thrilled to have Dr. Mancini as our guest expert today. And my name is Lisa Kristinak, and I'll be your moderator. And Amanda Lowe, off camera, will be our wonderful person handling any tech support that we need today. Today's event is funded by the National Institute on Disability, Independent Living, and Rehabilitation Research. This session is designed to be an interactive Q&A, not a traditional presentation. So for the next hour, Dr. Mancini will answer your questions related to today's topic, which is promoting health access and vibrant aging for older adults with a serious mental illness. So after I introduce Dr. Mancini, he'll have the opportunity to expand our topic. Then we'll dive right into your questions. So please feel free to start submitting your questions in the chat at any time. So now we are honored to have Dr. Mancini with us. He is a true leader in the field of mental health, addiction, and health access. Dr. Mancini's impact extends globally. He has worked at the local, state, and federal levels and has consulted internationally. His commitment to advocacy and education has also made waves in media with his award-winning documentaries and public service announcements addressing Latino mental health and substance use, earning him 6 Emmy awards. Among his many accolades, Dr. Mancini was recently honored with the 2024 William F. Callahan Leadership Award from NAADAC, the Association for Addiction Professionals, for his exceptional contributions to the field. He also chairs Mental Health America's National Board and serves on other influential organizations championing greater access to mental health care. Today, Dr. Mancini will help us navigate the intersection of aging, mental health, and recovery, exploring key strategies to advance health access, combat social isolation, and empower older adults to live vibrant, fulfilling lives. So welcome, Dr. Mancini. You just take center stage and take the next 10 or 15 minutes to expound on our topic, and then I'll pop back in and assist introducing any of the questions that our folks have for you today. So take it away.
Thank you so much, Lisa, and good morning, good afternoon, everyone, depending where you are in the world. Thank you so much for being here today, especially after reading in the chat that some of the places where you are, the weather is beautiful and you have many other options for activities today. I'm real honored that you chose to spend this hour with us. You know, when I was first invited to this, first word that came to mind was dignity. So aging with dignity and purpose is not only a universal aspiration, it's a professional and a personal aspiration as I continue this journey into life. But for older adults with serious mental illness or substance use disorders, there are barriers that sometimes stand in the way of thriving. And my goal in life is to help people be able to overcome challenges so they can thrive, they can belong, they can be part of this amazing world, this amazing life that we can have if we're given these opportunities. So today I wanted to kind of explore that intersection of aging, mental health, recovery, but mainly I developed 5 areas that I kind of want to center the discussion about that I will share with you in a moment. But I wanted to address things like social isolation, advocating for equitable access, holistic healthcare and recovery, so we can evolve into this purposeful aging as we foster that sense of community with lifelong learning and empowerment. So I wanted to start with a confession. My mother last year moved into an independent living, and I've gotten to meet some beautiful, amazing women and men who are living there. And you can see some of them have this spark, and they have this love for life, no matter how old they are, 80s, 90s. There's also hundreds at 101. So I asked one of the older person, what is the secret to aging gracefully? And she told me, honey, don't look in the mirror after 60 and everything will seem fine. But, and so I laughed a little about that. I said, well, that sounds kind of funny. But as I was um, thinking more about it, it reminded me that the way we age and the way we thrive has a lot to do with perspective. And it has a lot to do with the support that we get along the way. And what happens today, in my point of view, we don't have the opportunities to really help older individuals, older adults with serious mental illnesses, not just to age, but to be able to age vibrantly and to be able to achieve that. Now, when I talk about vibrant aging, I'm not just talking about, older folks that you see in their Adidas suits or taking a salsa class, even though I love when they do that. And if that's something that you're into or your clients are into, is wonderful, because I think movement is one of the biggest keys. But we're talking about living with purpose, finding joy, making sure that every individual, regardless of their mental health journey, has that chance to thrive as they grow older. So, this topic is also very important. Some of you may even know that the statistics better than I do, but one statistic that has been consistent is how people with serious mental illness live 10 to 25 years less than the general population. And I know it's a dated statistic, but we continue to see that happening in this world, in the work that we do. And it's not because people are aging faster. My belief is because we have systems around them that are not designed to support that mental, physical, and social needs as they grow older. So, aging is already difficult. My mother reminds me all the time, aging is difficult, aging is expensive. And when you add a mental health challenge to that, it's like playing with blindfolds on or one hand tied behind your back. So I really hope, and I want to invite that all of you will help me in participating in this discussion. I want to highlight 5 areas that I think are extremely detrimental to helping older adults with serious mental illnesses, not just survive, but thrive as vibrant elders in recovery, like a top 5 list. And of course, if you have items, then I would welcome for you to put those in the chat that Lisa is going to be monitoring, and we can discuss that. So, we want to be able that to walk out of here, we're saying, hey, I learned something new. There's something I can do better for myself or for the clients that I'm working with. And, it's hopefully it'll be a lively discussion. Nobody will fall asleep. Nobody will start multitasking while we are in this virtual session. So the first one is recovery-oriented care. So we need to stop treating aging as the end of the road, and we need to start treating it as that new chapter. Like when, your favorite show gets renewed, or you're looking forward to the next season of, I'm an opera lover, so I look forward to the next season of the opera. So recovery doesn't stop at a certain age, at 65 or 70. I personally am a person in long-term recovery since 1985, and I'm 62 years old. So I always believe my life is just starting, and is because I had opportunities to be able to learn how to thrive in recovery for all these years. Now, when we promote recovery-oriented care for older adults, we remind ourselves that this is relevant as individuals age. We need to make sure that our care emphasizes those strengths, those personal goals that change as we age, and that helps us achieve a quality of life that we want, fostering empowerment as we get older. Now, there's some considerations in promoted recovery-oriented care for adults of access and fairness, we need to make sure that recovery programs address the unique challenges of aging, like mobility limitations, chronic health conditions, changing social roles, loneliness or isolation, with a focus on inclusivity and respect for cultural and personal values of that individual. The second item I think it's important is combating isolation. So we know isolation is not good for everyone. You know, one of the main reasons my mother took this step is because her friends lived far away. She was living by herself independently, and she didn't like to drive that far, and her friends didn't drive. So a lot of the time there was not that connection. And in the facility that she's at now, there is connection. She met some wonderful people, so she doesn't have to struggle with that isolation. But it also happens to us. It happens to me. I'm sure it happened to some of you who are listening. Isolation is a really difficult area to deal with as we age, and part of that is more difficult for us to make new friends, to let people in, especially as we're dealing with our aging and any conditions that may come with that. So it's not good for anyone. But for older adults with a serious mental illness, it's like taking away the cell phone of your adolescent child. And you know, that's devastating. It's their whole world. So we need to build this community. The importance of social connections is extremely crucial for maintaining good mental health, or for maintaining a sense of purpose. So older adults with serious mental illnesses experience loneliness, which can undermine recovery and well-being, and it would lead to further isolation. And we need to consider things like peer-led support groups or mentorship programs, community-based activities that foster belonging, especially individuals from marginalized communities who may face additional barriers to social engagement. The third area that I think is extremely important is the access to holistic healthcare. Now, you're hearing a lot today, especially those of you that continue to be glued to the news, which, by the way, sidebar, limit your news intake if you want to have good mental health. Limit it to 1 hour a day or less if you want to have and keep good mental health. So access to holistic healthcare, we should be able to get any and everything that we need. Mental health, physical health, substance use recovery, it all has to come together. But some systems still operate like they're serving leftovers. They're operating with older principles, older modalities, older medications, older. So we need to make sure that we're providing access to new ways. I do a presentation on biohacking your mental health that talks about the importance of nutrition and sleeping. We need to make sure that we have this type of services. So aging adults with serious mental illness require integrated care that addresses mental health, physical health, spiritual health, financial health, all of that under one roof. And we need to make sure that we address the systemic barriers or any other kind of barriers like transportation, language, financial constraints that can limit access to that type of comprehensive care. The fourth point that I wanted to bring up today was purposeful aging. So we're never too old to learn something new. I am so happy that every single day I learn something new, and I hope that never stops in my life. Every day I learn something new, whether it's painting, gardening, volunteering. We need to make sure that these individuals, older adults in recovery, deserve that opportunity to find meaning. And, we all dogs can learn new tricks, and I hope that we understand that. So that sense of purpose, why am I getting up in the morning, is extremely important. So we need to provide those opportunities for growth that are essential for vibrant aging. And in order for us to do that, there is communication barriers, cultural barriers for older adults. Aging older adults, it's its own culture. And we need to make sure that we provide the tools to contribute to their communities, ensuring or including inclusivity for those individuals that have other languages, other cultural beliefs, other socioeconomic backgrounds. And the final one, the fifth one that I wanted to bring in today is policy advocacy. Now, in order for us to change systems, whether it's a private system or a public system, we need to make sure that we have the advocacy and the people that would help us advocate for changes when changes need to be made. We need advocacy that makes access and fairness to support services, to healthcare services for this population a reality. So when we talk about policy changes, is something that's needed if we want to create the system that supports recovery and vibrant aging. And these are things that address issues of housing, accessible healthcare, programs tailored to the older adults with serious mental illness. So we need to learn how to advocate. We also need to learn how to be supportive. There are people that sometimes get to a point they cannot advocate for themselves. You know, another lesson my mother taught me is whenever you go something as simple as going to the hospital or to the doctor's office or to the emergency room, you need someone to be there with you to help you advocate for that, because sometimes people are moving so fast in those systems that they can ignore you and they can discharge you without really giving a thorough look at what brought you there in the first place. So we need people to help us advocate for these issues. Before I leave you so I don't forget, and hopefully they will come up, we do have the new 988 crisis hotline. I hope everyone is aware of that. If not, please learn about it. It's the 911 for mental health issues, and it's 24/7. It's free, and mental health professionals answer it. So hopefully now we can talk about these issues. If you have other areas that you feel also need to be included, I welcome them. And I think I already see a comment in the chat. What are the challenges I can share about long-term care facilities and how they prioritize mental health and aging? Do I think antipsychotic drugs are overutilized and create more isolation in nursing home settings? And how do I think states should be advocating for long-term care? Thank you so much, Lisa. These are some very heavy questions. And again, my answers, this is Pierluigi's personal opinion, not Lisa's, not Amanda's. This is my personal opinion. So if somebody doesn't like him, just contact me directly. But long-term facilities, my answer is going to be, it depends. It depends on the investment and the understanding of long-term facilities about mental health issues in an aging population. I have seen facilities that have an incredible team that are aware. They walk around the place, they notice changes in the individuals, they have a team meeting, they discuss, they have professionals that they can call in and have interviews, formal and informal interviews with the client, in order to be proactive when they notice that there are things that may not be working, or there's some development to how the person is reacting to being there. I've seen others that don't have that. I've seen others that pretty much just, make their rounds, make sure that people come down for dinner, or if they are in assisted care, that they are fed, or they have someone there for physical, to avoid physical problems than emotional problems. So I've seen both of them. What I do believe is that there needs to be a standardized, and no matter where you are or what facility you're in, we need to have these protocols that everyone that comes into those facilities is trained on, so they can understand and they can see what it is that they need to be looking for when someone is beginning to have either a cognitive decline or developing a mental health issue. The other thing I have not seen is, support groups, peer-led groups that I mentioned. Long-term care facilities, if they are receiving individuals, aging individuals, 80, 85, 90, years old, and these are individuals that are recovering from a mental illness, then there should be a support group. There should be a part of the program for those individuals, just like they have physical therapy for the individuals that want to make sure mobility continues. They need to have recovery groups or access to some kind of recovery programs, so those individuals that are recovering from a mental illness can continue their recovery. So I hope that covered the first question. The second question, antipsychotic medications. Oh boy. Okay, I hope I don't get in trouble. So I do feel that we over-medicate people in this country. The reality is that there is a lot of people in this country that are taking medications that may not be taking medications for life. There's a lot of psychotropics that are supposed to be temporary, 6 months, a year, while you develop skills to overcome whatever barrier you may have. Now, at the same time, there are serious mental illnesses that people have that do require medications that could be for life. So I think it goes back to, where was the person diagnosed? Who made the diagnosis? Was that system set up in a way to take a look at the full picture of that individual? Or was it a system that was so overloaded that it was the easiest decision to make, just to make sure that this person was taking medications? So I do believe there are instances where medications are lifesavers. Medications is what's going to keep that person balanced so they can develop these new skills and be able to thrive in life. But I also believe that sometimes we do over-medicate. We do prescribe for individuals longer than they may need to be on those medications. Again, it's a case-by-case basis, but I think it goes back to the beginning. And the beginning is when the person is being assessed, when the person is being diagnosed, that individual needs to make sure that they have the entire picture of who is sitting in front of them in order for them to be able to do that. Again, if the system is not set up to provide that information, then a decision is going to be made with partial information instead of all the information that the person decides. It's kind of the same thing. It's almost identical, the same conversation I have when we talk about children and adolescents. It's gotten to the point that we want quiet, well-behaved classrooms. Well, if you're an 8 or 9 or 10 or 11-year-old boy or girl, you have a lot of energy, and then many times the solution is, let's just medicate them so they can sit still in their desk for the school day. I think that's wrong. I think that's what we have, kids that are over medicated. So I think we have to take a look at how that works out. And I do believe if you over medicate someone, it creates not only more isolation, but it really prevents them. It prevents them from being or from feeling like they are contributing to life and contributing to society. So it contributes to that level of isolation because they are unable to participate in life if they're overly medicated. So again, I think it's something that needs to be looked at on an individual basis, but a big part of it is, I think, how is the system set up to meet the needs of people with serious mental illness who are living in these facilities. And what do I think states should be advocating for long-term care? Well, I think, a couple of the points that I already made. Now, states are all different, as you know, and some states are doing wonderful work, and they have great facilities, they pay their people well, they have the right ratios. And then, some states struggle because, again, the system needs to be set up to take care of the population in a proper way, not just to be an afterthought, not just to fund them when there is money and cut their funding when there's no money. It needs to be something permanent. It needs to be a commitment from that facility, from that system, from that state. Thank you, Lisa.
All right, that was great. Yes, thank you, Lisa, for that question. questions. So keep them coming. Keep them coming. We do have a question that was sent before, which I think would be on your first point that you made about recovery-oriented care for us older adults. Said, what role do caregivers and family members play in supporting aging individuals in recovery?
Oh, great question. So, family members are key. And unfortunately, the way society works in the United States, because of school or because of work, we move. So you end up having families in different states, in different parts of the country. That makes it difficult to be present, to visit on the weekends, or to go by and have dinner with your loved one at one of these long-term homes, or if they're living by themselves in another part. So that is a struggle. That is something that can be very difficult. And I've met many family members that feel very guilty that they're not able to be there either for a holiday or for another celebration, because travel is really expensive, and now the kids have to pay for their own seats and all of these things. So the role of family members, and I'll start with that, is to continue to provide that emotional support, to make sure that we check in emotionally with our loved one, ask them questions. Are you taking your medication? Are you having any reactions? Is there anything that you need? Are you walking? Are you getting some fresh air? Making sure that they are being provided the opportunity to participate in life with those very simple instructions, making sure that they have and they understand the resources that may be available in the facility or in the community that they could be taken care of. Now, of course, that's going to be different depending on the condition of your loved one. If they're over medicated, or if they're have mobility issues, then it will be different for each individual. But I think family members, the one item that I constantly hear from family members is their regret that they were not there. Now, today, we can have virtual visits. So if I'm in another state, I can teach my loved one or their caretakers how to connect them, so we can have a virtual visit and they can at least see my face and my kid's face and other people. So I think we need to, as family members, carve out the time and not forget about these individuals. I see people in independent living or long-term care who I feel they've been completely abandoned. They don't hear from their family. They don't see their family, and that is really sad. It's a very sad place to do. Now, caregivers in supporting aging individuals in recovery, as I mentioned earlier, I think your system and your facility, if you're aware that 1% or 5% or more of your residents are in recovery from mental illness or from substance use disorders, that they have support systems inside of that facility, that they have the ability to provide a space for people in recovery to come together to talk about how they're doing, how they're feeling, any issues that they're having. Also, to facilitate whether is an individual coming to the facility or have transportation for the resident to go visit their mental health provider. So if they have a counselor, a peer, a psychiatrist, whoever it is, to make sure that that doesn't stop. So the caregiver's job is to make sure that whatever mental health need that person has, if they're on medications, make sure they have their medication, help them take the medication if they need help with that, transportation for visits or the space within the facility for them to have their their support groups and be able to help them improve their quality of life so they can thrive in recovery as they age. Thank you. Good question.
Thank you. We have a follow-up question to that from Veronica. She says, have you met family members who worsened the patient's prognosis Family members also suffer depressive symptoms due to a mental health condition of their loved ones.
Excellent question, Veronica. Thank you so much, because we do. We often forget that we are part of the equation. We are part of this equation of a loved one who now is not functioning at the same level that they were while we were growing up, especially if this was a loved one who was extremely active. I've seen people, even in my family, extremely intelligent, successful business people, and then through aging, they develop either dementia or Alzheimer's. And it is heartbreaking for me, for us to see our loved ones begin to deteriorate that way. So, yes, family members need to understand we are part of this also. We need to take care of our own mental health. We need to have our own resources to be able to process what it is that our loved one is going through. How can I take care of myself? How can I be in a state of good mental health so I can be the best son, daughter, aunt, uncle, whatever my relationship is to my loved one, that that I can provide. You know, when families, and there's this one person in where my mother is now, that she doesn't have a family member there, but she has the mother of some high school friends, lifelong friends, and she lives close to the facility, and she goes there almost every day, and visits and keeps them in company, gives them rides to places. So if we're not there close to them, maybe there's someone there that can also help us by going by and checking in on them. So, but that family guilt or the family inability to participate can be very distressful. So I do recommend find our own resources for that. Now, back to your first question, which is kind of a tricky question. Can family members worsen the prognosis? Um, I think family members can contribute to an elder person, whether they're in recovery from serious mental illness or not. I think we can worsen their isolation and loneliness. I think that if we are not able to maintain social contact through a telephone call, through a video call, through a text, or a personal visit, if it's possible, on a minimum a weekly basis, preferably 3 times a week if we can, or daily in some cases. It's going to be more difficult for that individual to stay balanced with their own recovery. Now, I've seen individuals where the family is not as active, and sometimes it's because of family issues, maybe some family trauma, some family discussions. I've seen many over the last 18 months or so, families that are broken up because of politics. And by the way, sidebar, you should never let politics come between you and the love of your family. You just need to have to learn not to talk about politics when you're together. But politics should never. I saw people cancel visits, cancel dinners, cancel celebrations. I mean, it was very, very difficult to watch. But there are divided families, right? But we need to be able to support each other, especially when we have someone who is aging and who's beginning to have some physical, emotional, spiritual challenges as they do that. So I think that the lack of family member presence, again, virtual, telephone, or in person, does help deteriorate that mental health for that individual. It makes it more difficult, especially if they're struggling and they just don't have that connection within the facility. Some people are able to build those connections within the facility and kind of helps, but there are many who don't build that connection and they end up further isolating. Thank you.
Great question. Great question. You mentioned earlier, and this goes along with another question that was asked, and I am a person in long-term recovery myself, and I know what having peer support did in my own personal life. Um, so this question is about, your experience and your knowledge about the most effective peer-led initiatives for reducing isolation among our older adults who are in recovery.
Oh, yes. And I'm a big fan of peers and certified peers. And I highlight certified because today we have wonderful training programs all over the country where a person in recovery from mental illness or a person in recovery from substance use disorders actually receives um, very in-depth training on how to support other peers. Now, let me make a pause here because nationally, I think we're very, very, very far behind on geriatric mental health and substance use disorder treatment. There are very few people who actually know how to serve this population. Now, I believe that the certified peer movement that started here in Georgia, pat on the back, um, is something that can really help us work out of that. So you have today certified peer for adults, certified peer for youth, certified peers for families. I think we need certified peers for geriatric care because this population that's aging and with all of the changes that we've seen of eating healthier and working out longer, we're going to have healthier older people. So we're going to be around longer than previous generations, and we're not really equipped to handle that. But I think that the value of peers is that you have someone with the training, with the opportunity to be present for you, to be able to provide support groups in these facilities, to be able to provide recovery coaching, senior-led wellness programs that can create opportunities for connection and reduce loneliness. Certified peers can promote activities or bring activities to the facility. They can help incorporate those shared lived experiences, which are so critical because they tend to be most impactful. There's nothing better than having someone who immediately I identify with because I know they've walked part of the same path that I've walked. They may have walked it differently or got here differently, but I understand that they understand. So I think that having certified peers for geriatric care is a movement that really needs to take off in this country. I know that clinically, we don't have enough licensed therapists that can understand geriatric care. Definitely don't have enough psychiatrists because we don't have enough psychiatrists in general. And the same way that we don't have enough children's psychiatrists, we don't have enough geriatric psychiatrists. I call them the unicorns. And we need to be able to provide that support. So I think we need to go back and again, part of advocacy, part of systems is to be able to advocate for the workforce for older populations in recovery from mental illness or from substance use disorders. Good question.
Awesome. Thank you. This question goes along with your point about access to holistic care. What are the biggest barriers to behavioral health access for the aging population, and how can we work to overcome them?
Ah, so my professional career is all about breaking barriers, and I think that there are so many barriers for um, so much of the work that we do, and many of them I've discovered they are unconscious. People don't understand that they have barriers in place for people to access their institution or their facility or to serve an older person in recovery. And but then there's others that have barriers, but they know the barriers are there, right? So there are some people you can help understand and make changes, and then some other people that unfortunately we're not able to reach. But I think that the biggest barrier that we have in this country is stigma. And until we are able to normalize this conversation, unless we're able to talk about mental health disorders, substance use disorders, the same way we talk about broken bones or getting the flu or having a headache or maybe even a serious physical illness like being diagnosed with cancer, unless we're able to do the same when we talk about people that are suffering or diagnosed with anxiety, depression, bipolar disorder, even schizophrenia, the barrier of stigma is going to continue to help people suffer in silence. Now, when someone gets placed or moves into an independent facility or a long-term care facility, it's always scary. I mean, you're leaving a place that for most people, a place they felt safe, that they had known for a very long time. And now they're moving into a new place with people they don't know, with new structures, with a different bed or a different place where I'm going to sleep. Um, so the and depending on where the location is, you may even lost the support system that you had in place for your mental health or your substance use disorder. So stigma, it'll be more difficult for me to move into a new facility and from the get-go say, I'm a person in recovery from a mental illness. Is anyone else here in recovery from a mental illness, right? So again, the facility, the system needs to make sure that there is a path for people that are moving in with diagnoses or being in recovery for mental illness, substance use disorders, to connect with others, to have a safe space for their recovery. So I think stigma becomes the biggest problem. The other one that I've seen is financial. Now, as I mentioned earlier, my mother, a very wise woman, tells me aging is expensive. So whether you're in a private facility or even a public facility, money plays a role. So many people have financial barriers and they're not able to move into these facilities, or if they move into the facilities, they may come a point where they can no longer afford it. So that's another barrier for people to access care for aging populations. Transportation issues, many people stop driving after 70 or 80, depending on the facility or depending where you live now. Do you have transportation for your support for your mental health condition or your substance use disorder? And a lot of people say, oh, well, we have virtual now. Well, half of this country doesn't have the bandwidth to hold the virtual session like we're holding today. I know in Georgia, if you know Georgia, Atlanta is like in the north, Macon is in the middle. When you go past Macon to the south, unless you have a certain telephone carrier, your cell phone may not work. And many people in rural areas in the United States do not have internet. So they don't have the ability to access the internet or to have this kind of virtual access. So I think communication, the same, if you're someone who's aging and you've been here a long time, but your English is still limited, we definitely don't have access for people that are not fluent in English in this country. And that includes deaf and hard of hearing. There are very few clinicians who know American Sign Language. So we have a crisis there where we don't have linguistic access for individuals that need to be served in their language, or even people that have understandings of mental health from different cultures. Not everyone believes in the westernized medicine way that we treat mental illness in the United States. Some people have more holistic or more traditional Eastern medicine. So we need to learn that, and we need to see if that's something that we can be providing to our to our community, aging people in recovery. So, I tell state systems, I tell private, public systems, this type of investment needs to be a budget line item. This is not an afterthought. Oh, we have a little money left over. Let's have a celebration for the people in recovery who live here. No, this needs to be purposeful. It needs to be an investment in that community that's part of the residence or the place where you live, so they can have the opportunity to thrive as they age in recovery. So we need to make sure that those efforts continue to be improved and continue to be advocated for. So there's things like integrated care, when the same way that a facility looks at investment into physical care, they need to make sure that they expand that budget and they make investment for mental health care. Good question.
All right, thank you. We do have a question that just popped up from Kenneth. Traumatic intrusions become more immediate and intense as a normal process of aging. Recovery is different in elderly than when younger. Many people only have traumatic symptoms when older. What do you recommend for trauma symptoms when older? What do you recommend for trauma treatment for older people? Thank you, Kenneth.
Oof. Yes, thank you, Kenneth. It's again, it's a very it's a very strong question in many levels. I've seen people as they age that, and this may be people that have addressed early trauma, right? So we know from many studies that many of us are affected from childhood with traumatic issues that we don't get to address, or we don't get to address all of them, or we may not even become aware of them until we're older. So I think that plays a role in the in how we approach trauma treatment for older people. There's also the physical and the cognitive state of that individual in order to address this issue. I've seen older people that it is when they get older, sometimes when they move into a facility, when they actually remember the trauma or begin to remember the trauma. So will they have the resources to properly address that? Now, if there's one thing we've learned in the last few years, is we have amazing modalities to treat trauma today. And we're seeing people, and like you asked in your question, younger people be able to thrive by overcoming the challenges that trauma caused in their life. So we are seeing that. How do you transfer that to an older person that may be having some cognitive decline, to an older person that now finds themselves in a different living facility that may or may not have the support services that they're going to need as they walk through processing this trauma to try and find recovery from it? So I think that my recommendation for trauma treatment for older adults is for the systems to be able to be equipped with the opportunity, with the space, with the professionals, and the supports for that individual to do that work as they are older now, and they have many more limitations, physical limitations, maybe mental limitations, for them to be able to begin to process that. So I think that now, if the person is in recovery for many years from a mental health condition or a serious mental illness, and then they begin to remember part of their trauma, I think that they're in a good position to be able to address that, because they can use the strength from their own recovery that they already have to be able to help them, guide them through this. But if the person begins to remember trauma as an older individual, and they have not had the benefit of mental health care, of counseling, of medication, of structure for mental health conditions, then I think it may be a little more difficult for them to be able to move to that next step. Thank you.
Well, I think we have time for one more question that's popped up from Lisa. What holistics rise to test to promote mental health that are proven best practice, do you think? Is it peers, light and color therapy, sounds, environmental activity, and people? Did peers stand out in better outcomes?
Oof, another good question. So when we look at holistic approaches that are tested for promoting mental health, peer support, environmental factors, activity-based interventions. There's sensory therapies like light, color, sound. They've shown benefits. Peer support stands out as one of the most effective interventions. I'm a big believer of peer support, especially in individuals in recovery and older adults. So I think that peer-led interventions improve recovery outcomes. They reduce social isolation. They give you that sense of belonging. They provide that lived experience, emotional support. It's impactful for both mental health issues and substance use disorders. I also think activity-based therapies like physical movement, yoga, Tai Chi, walking programs. There's a lot of water aerobics, which is excellent for older individuals. They improve mood. They also help with cognitive function, reduce symptoms, anxiety, and depression. Also engagement in arts and music. There are people that music, they may forget your name, but they can sit at a piano and play a Bach symphony that they'll never forget. So I think music is actually something that can help a lot of people, and we need to continue to promote that. Also, I think environmental design, nature-based therapy. So if the facility or the community doesn't have to be inside the facility, it could be around the facility. If you have gardens, if you have parks, if you have fountains, in Mental Health America a couple of years ago, we had this program where we're trying to help communities understand that yes, green is good, blue is good, but if you have green and blue at the same time, it's even better. Meaning that if you're going to build a park, if you're going to build a community walking area, don't just focus on the green grass. Have a fountain, have a lake, have a little pond. If you have green and blue, it's going to be a lot better for the individual, because it's a more calming environment that's going to help that individual. So incorporate nature into those spaces. When I was little, we grew up in our home. We had internal gardens inside the home. And then my mother used to have these beautiful gardens outside the home. And there was always this sense of peace and this sense of serenity when we were in that space, in those gardens. Light, color, sound therapy, exposure to natural sunlight or light therapy right here next to me. You can't see it, but I have my red light therapy that I do most days. I need to do it every day. Is where I want to build up to, but life gets busy. But I have it here. So all that helps to be effective for depression, for our circadian rhythm. We need to also look at technology, virtual social engagement, like I mentioned, with this kind of opportunities to be online. So peer-led programs demonstrate strong outcomes. They combine everything that I've mentioned to give us the opportunity to be present, to be with individuals, and coming from a peer, we're able to have better outcomes for these individuals. Great question, Lisa. Thank you.
Just to kind of wrap up, we did with one last question for a minute or two. around one of the last point you made was around policy advocacy and health equity. So how can professionals and our community effectively advocate for aging-friendly behavioral health practices? So how can we get involved as a community or practitioners?
Well, it's I love that question for many reasons. Again, we're living on a day-to-day basis. Those of you that follow national politics, there's the budget discussion, what the House put out yesterday. Many people are screaming, "Oh my God!" All these cuts. It's difficult. These are very serious, difficult times, and we need to be able to advocate for what our community needs, what our clients need. I think that the policies that will ensure that every individual has access to mental health and substance use disorder care is critical. We need to make sure that professionals are getting paid at a decent rate, at a rate that's a livable rate, not less than others. We need to make sure that we have these certified programs. And the best way that I've ever seen policy get written and put into law is by sharing personal experiences. Right now or whenever your legislator comes back to your hometown and they're visiting or they're having their town hall meetings, show up, tell your personal story, whether it's you who are recovering and you want to make sure that the legislators understand that these services are needed so people can recover, or if you're a person that's trying to get help and don't have access or your program, your insurance doesn't cover it, they need to hear that as well. So personal testimony for me has always been the best way that we can have policy become law. Right now, we need to make sure that many people are receiving behavioral health services through Medicaid. So we need to make sure that if they're going to make changes to Medicaid, we need to advocate that they don't pay the price by cutting behavioral health, mental health, substance use disorder services. The same thing with Medicare. A lot of providers stop taking Medicare because it doesn't pay enough, right? So we need to advocate. If many people, many of our older clients, that's their insurance. That's what pays. It's what they paid into the system now to be able to get these services. We need to make sure that there are behavioral health services and that those providers get paid enough so they can accept that form of payment. Unfortunately, we do have two healthcare systems in this country. If you're wealthy, you can afford the best of the best. If you're not wealthy, then you have what we have, and that's really, it's just reality. It's neither good or bad. It's just reality. But we need to make sure that people have access. But the best way for us to advocate is go to your legislators, share your personal story, whether it's a positive outcome, a negative outcome, and make sure that they understand the importance of providing these services to aging individuals who are in recovery from mental illness or substance use disorders.
Thank you, thank you, thank you. Well, thank you, Dr. Mancini, for sharing your expertise and most importantly, your passion with us today and your heart. We appreciate everybody that came on today, all your insightful questions, and just that you showed up today to engage. And we have many thank yous coming up to you, Dr. Mancini, to show their appreciation for answering questions and just being with us today. We appreciate it. You please take a moment to complete the survey. Your feedback is crucial as we continue to improve our events. Thank you all, and we look forward to seeing everybody again at our future AMAs, and I hope you'll keep coming back and sharing with us. And thank you so much, Dr. Mancini. We surely appreciate everything you brought to us today, and we look forward to collaborating with you again in the future.
Thank you so much, Lisa. Thank you, Amanda. And thank you, everyone, for showing up today. I really appreciate it.